Everybody. I'm sorry to keep you away from your lunch just for a few minutes. So again, here are my disclosures, not only Siemens, but also some drug companies. Now, we come into a really difficult time when we start to think about our patients once the cancer comes back. Because although we are making progress in the breast, we're not making so much progress in terms of disease recurrence, especially when it's systemic. And this actually contributes to poor outcomes. And I will show you that to start with. So let's start with this patient. This is a patient who's had a biphasic tumor, ER positive, but also triple negative. She has all the normal treatments, as you might imagine, mastectomy, adjuvant treatments, radiotherapy, and then a couple of years later she pitches up with what is chest pain. And here is the bone scan showing a hot area, and here is the CT scan. So then the question arises, is this oligometastatic disease, or is this just a radiation fracture? In other words, would you advise as radiologists to give a systemic chemotherapy, some sort of systemic therapy, or are you going to advise a painkiller? These are the questions that your physicians face on a daily basis, and frankly, using current accepted standards, you can't actually answer that question. If you think you can, you are wrong. Because if you do a whole body MRI scan in this setting, what you notice is there are 1, 2, 3, 4, 5, 6, 7, 8 metastases, i.e. polymetastatic disease. Not only that, but you've actually got a liver metastasis. So she needs chemotherapy, not hormonal therapy, and that's been the impact of just one scan. And that is why we should look at current guidelines very, very critically. And I'm extremely critical of the current guidelines. So look at these 2017 guidelines. They say that the minimal workup includes a CT scan of the chest, abdomen, and pelvis. All right? But we know that it doesn't work very well. They also fail to acknowledge what we all know, which is there's a poor sensitivity for bone scans and CT scans. So you'll see comments like this. Look at the bone windows on a CT scan to detect metastases. I mean, this is just complete crap. And the thing is, you know, these guidelines, they are not being written by radiologists. They are being written by the clinicians. And that's because we are not engaging in a big way and in a substantial way in the way that we should. So how good or how bad are bone scans and CT scans for detecting the presence of metastatic disease and the volume of disease? Are they really fit for purpose in 2018? Well, here's a prospective clinical trial which looked at high-risk breast cancer and high-risk prostate cancer, not known to have metastatic disease, and essentially compared whole-body MRI scanning with a couple of types of bone scans, but also sodium fluoride PET-CT. And the bottom line is that the MRI has a very similar sensitivity for bone disease as sodium fluoride, which is what you would expect, but clearly outperforms SPECT-CT and planar bone scans. So if you guys are using bone scans, which I call bullshit scans, please stop. Because, in fact, you are doing your patients a disservice. Numerous meta-analyses are also showing this. So, for example, this paper that was published in 2011 clearly shows for metastatic disease, MRI scans, PET scans outperform CT scans and bone scans. I mean, look at this bone scan data. So yes, it was fine 20 years ago, but in 2018, you really should be thinking about moving away to a new method of doing this. The other problem is that with new treatments coming on, the heterogeneity of response is not captured by these new technologies. So if you look at the guidelines again, the guidelines say do bone scans, do CT scans to follow your patients on new treatments. I mean, here is the ESMO guideline. Okay? It doesn't mention, you can do a PET scan, but it's optional. The problem with CT scans and bone scans is that 30 to 40% of patients have disease that's non-measurable, number one. So a lot of times your clinicians will use tumor markers to do this. But tumor markers don't actually work very well. And I just wanted to give you an example of the type of mispractice that goes on in the metastatic setting. So here's a patient who's had breast cancer. This is a recurrence in the neck. She has metastatic liver disease. This is a whole body diffusion scan, by the way. And you can see there's a raised CA15-3. Okay. So she gets radiotherapy to the neck because she's symptomatic. And then she gets treated with a change in hormonal therapy. And you can see that the tumor marker increases, the liver metastases increase, and the neck lymph nodes are beginning to go down. So in this particular instance, it looks like the tumor marker works. But look what happens next. We change the chemotherapy because she's progressed in the liver to capecitabine. And look, the liver metastases have progressed. The neck lymph nodes have, of course, gone away because there's been previous radiotherapy. But look at the CA125. It's gone down. And this is the problem. And the request form says, please confirm degree of response. Actually, this is progression. But the important thing is there's been a 6-month delay in changing this patient's treatment. And you have not done this patient any favors at all because of this type of thing. And we see this all the time. Here's a patient with a pelvic whole body diffusion scan, just a slice. Here is a metastasis. Difficult to see on the CT scans. The patient gets treated with a hormonal therapy, gets standard of care, and here is the standard of care CT called no change. Then the patient develops increasing pain, has another CT, and now the CT is being abnormal, and this is the degree of progression. So if you look at what happened to this woman, and you say, okay, what the hell happened here in 1 year? What you notice is her volume of tumor increased from 53 cc's to 470 cc's. But you have no idea what happened in that 1 year. You have no idea whether she responded and got worse, whether she just got worse, or she was stable and you got worse. You have absolutely no clue. And we are treating patients blind because of this. And this is causing a real issue because we don't see volume changes, we don't see the tumor, and we don't see heterogeneity in response. Now, we know that if we wait too late, we disadvantage patients. That's been shown. We know that the more cancer there is, the worse patients will survive. So if you measure tumor volumes, we know that if you have more bone disease, you die early. If you have more lymph node disease, you die early. If you have liver disease, you die early. So don't disadvantage your patients. Don't wait to switch the treatment because you're putting your patients at a disadvantage. So this ability of not being able to switch treatments in a timely fashion means that many of your patients can't participate in precision oncology. And this leads to increased costs. Now, here's another example if you needed one. So look at this patient. This patient is receiving pertuzumab and Zometa. Look what stable. No, not stable. Progression. But the worst thing is pertuzumab. Do you know how much pertuzumab costs? Do you know how much you are costing your health systems because you're not monitoring treatments well? The cost of trastuzumab or Herceptin is $55,000 US. You know what? Add pertuzumab, that goes to $150,000, 3 times as much. Right? Why are we giving patients expensive drugs and putting them at a disadvantage and then wasting money, putting money down the toilet? And this is crazy. We need to change this. And we need to change it by looking at bone more carefully. Now, there are many ways of looking at the bone, apart from CT scans and BS scans. What we can do is we can do PET scans. We can do whole body MRI scans, and that's what I'm here to talk to you about today. The whole body MRI scan is a multi-parametric assessment of the bone marrow. Just like you do multi-parametric assessments of the prostate gland and of the breast, you can do this of the bone marrow. And you see lesions that look like this and lesions that look like this. These are bone metastases. Now, let's figure out why you get a ring that looks like this. And here you need to know some bone biology. Now, I know you guys know breast biology, but do you know bone biology? Probably not. But do you realize that 55% of your patients, when they relapse, will have bone-only disease? You should know this. 55% when they relapse. And breast cancer still kills patients. So you need to know some bone biology. So you can have osteoclastic activation, which leads to these osteolytic lesions. Everybody has seen this. But you can get this osteoblastic recruitment, which leads to these areas of calcification with tumor around the margins. And you can see these tumors looking like rings. Can you see that? There's a low density center in the middle, and that's due to this little calcification in the middle. And you can prove this. On mouse models, you can show that the peripheral ring around the edge here are tumor cells. And these, you can see, these are forming glandular elements. And here are osteoclasts eating into the cortical bone. So there's a biological basis for what you see on the images. And we know the lower is the ADC, the more cancer cells there are in the bone. If you drill the bone and look at it, count the number of cells like this paper has done recently. The higher the signal intensity, the more cancer cells. The lower the ADC, the more the cancer cells. The lower the fat fraction, the more the cancer cells. So there are biological correlates of what you see. Now, so diffusion imaging like this patient is sensitive to cellularity, but also to cellular viability, cell kill. And that's where the application for therapy response occurs. There is standardization of this technique available. Potentially, every one of you with a modern CT system less than 10 years old should be able to do this. There's no reason you can't do this. In fact, a policeman can look at this and say, where is the cancer? It's quick, it's easy to do. There's no compression of the breast. Patients lie there for about 45 minutes. There's no radiation, and it's quantitative. And I just wanted to show you this quantitative aspects for the whole body. So this is some software that's being developed by Siemens. You can see we can use this software to quantify the amount of tumor, and here is the ADC value before, and here's the value afterwards, and that change in that histogram reflects cell kill. So the fewer the cells, the more cell kill you've got with your treatment, the greater is the shift of the histogram to the right side, which you can see. But you can back map this onto the body. You can back map onto the body and say, how much cancer is it, and where is the cancer still there? So for example, it starts off as all red, and it then becomes green and red. So my clinicians, they love these pictures because they understand traffic light systems, right? All your clinicians will understand traffic lights. Red is bad, green is good, and yellow is in the middle, right? Okay, so you can think about this scientifically. No treatment response, likely to be responding, or highly likely to be responding, okay? So you can do something like this. Now, it turns out that the variability, the measurement variability of ADCs is very good. It's excellent. So you can see a 12% change in ADC as being real. 12% change. So if the average tumor ADC is about 1,000, a change of more than 120 is real. Is it biologically meaningful? That's a different question, but that is actually real. And in fact, if you do in the whole body, you look at volunteers, you look at prostate cancer metastases, if you look at the entire tumor volume, look at the figures. The figures are great. It's about 6 to 12% change. So take 10%, take 12%, that's a real change. So highly reproducible technique, and the inter and intra-observer variability is also excellent. So there's no reason why you shouldn't say this technique isn't very good. Now, some of you will say, my patients prefer a CT scan, right? That may be true. But when you ask patients, you may say, as a doctor, I feel this, but when you ask patients, do the patient acceptability questionnaires, right? Yes, whole body MRI takes longer. It takes 45 minutes. Okay, I gave you that. A CT scan is 5 minutes. But if you ask about satisfaction, about preferences, about willingness to repeat the examination, the scores are very high indeed. Okay, so patients will come back if they know they are being monitored carefully. Now, this is our practice in terms of breast cancer. So here is our whole body MRI scans per year for all comers. And about half of this is breast cancer. So this is our breast cancers. So this is in 2016. We did between 750 and 800 patients. Right? These are the number of unique referrals. So you can see the number of unique referrals is increasing. The number of repeat visits are also increasing. Because it was interesting that when we introduced this in 2010, 2012, it was mostly about detection and characterization. But the clinicians learned that actually for monitoring response, it was actually a very, very good tool. So you can see right now we do many more scans as repeat visits. So who are we doing? Well, the classical example is a bone scan that needs to be sorted out. And I mean, this is clearly all degenerative, and the CT scan shows it's degenerative, but they decided to do an MRI anyway, and yes, it's degenerative. So this is one example. Here is a patient who was actually referred from a CT scan saying query lesion in the right iliac bone. When you do this, you can see on the fat fraction map, for example, on the diffusion example, and this was the area in question, there is no signal, it's full of fat, this is a benign lesion. Right, so you've gone from an equivocal lesion to a benign lesion. Right? And MRI just sorts it out. Aromatase inhibitor arthralgia, very, very common. 30-40% of your patients are getting pain with aromatase inhibitors. They're worried that the cancer is coming back. The clinician's not really worried because he's seen it before. You show them a scan that looks like this, you don't have any cancer, don't worry about it, the aromatase inhibitor arthralgia will get better. They feel better, I'm telling you that. Okay. The other group of patients that we look at a lot are the high-risk, locally advanced breast cancers, the inflammatory cancers, the triple negatives, and the early local regional relapse. So, I mean, here is an example of somebody who has a locally a multifocal right breast cancer with axillary nodal disease, but actually has a normal bone marrow pattern. This is a patient with a slightly smaller tumor here in the left breast. You can see supraclavicular phospholymphadenopathy and a number of bone metastases scattered all over the place. So this patient is clearly metastatic. And look at this woman. This woman is pregnant and has breast cancer. Every single one of you has patients like this, right? None of you don't have this. How are you staging them now? How are you staging them now? This lady here, so here's the baby. Let me just switch it around. Here's the baby, the placenta in the front. She's got multifocal left breast cancer, lymph nodes in the left axilla, in the internal mammary chain, and here are some axillary lymph nodes. So we gave her chemotherapy while she was pregnant, delivered the baby, and this is the post-chemo, post-birth appearance. You can see she has reconstructions, and these lymph nodes are actually inflammatory following the reconstructions. But then look what happens. She has axillary nodal relapse, she has bone relapse, she gets chemotherapy, unfortunately she progresses. She's got metastases in the bone marrow all over the place, and she's got liver disease. Unfortunately, she passes away. Her child is still alive. Now, this is the power of the technique, right? Detect, treat, deliver the baby, try to salvage her, fail, because they will all die. Triple negatives in breast cancer will always die when they are in pregnancy. Okay, so there is a real opportunity to be able to follow these patients, particularly those patients with locally advanced disease and metastatic disease. And here's another example. So this patient is getting hormonal therapy. So here we are, a small locally advanced breast cancer, a couple of small bone metastases, seems to get better, seems to be getting a bit worse. Now, difficult to see, isn't it? Let's just magnify that up, just to make it very obvious for you. You can see that the primary tumor starts getting bigger, axillary lymph nodes are getting bigger, she's developing liver metastases, bone metastases, and then she just continues to progress. We couldn't salvage her, right? We just couldn't salvage her. But we were at least able to try to intervene appropriately when the tumor volume was least. And in fact, you know, many of your clinicians will say, I can just monitor the breast. I don't care about the bones. I can just monitor the breast because I know what the hell is going on. Actually, that is completely incorrect. They do not know what's going on. Because when we looked at 31 patients with local regional relapse or locally advanced breast cancer and bone metastases, the interesting thing is the progression occurred in 80% of cases in the metastatic sites, not in the local site. So if you're just palpating the breast and then looking at the chest wall, that is not telling you about what is going on in the rest of the body. And this is what I mean by heterogeneity of response. Another key group is these people who have multiple treatments and then develop this pseudo-cirrhotic picture, or what's now called regenerative nodular hyperplasia. When we look at images like this, we have no idea about what is the volume of active disease within that. We have no idea. MRI sorts that out for you. It's easy. It's, in this particular instance, this is a look at the ADC maps. You can see it's all necrotic tissue. MRI, it really works very well. And we had to prove that MRI was not inferior to CT. Can you imagine this? MRI was not inferior to CT. So we took 43 patients with breast cancer. We blind read the MRI, the CT, and the bullshit bone scans. Okay. And we followed them until they progressed. You know what? MRI showed progression when CT was stable in 66% of cases. So CT scan was saying stable, MRI was saying definite progression, please change the treatment. In 66% of cases. In the rest, it was CT scans and the MRIs were concordant, but there was not one case out of 43. And if you know this is statistically significant, there was not one case where a CT showed progression and the MRI did not. And bone scans, when you knew the patient was progressing, the bone scans were negative. Were showing no change. So here's an example of a patient who progresses over about a year. The CT scan is reported as stable. The MRI, every one of you can see that there is more disease here. You need to change. The volume of tumor is probably double. And the bone scan says disease extent unchanged, no increase or decrease in the volume of lesions. You keep treating this patient, you are putting this patient at a disadvantage. The problem is, you're still doing this now in the clinic. Are you not? Every single one of you. Really, you should not be doing this. And we have found that it's impacting in the clinic. So we looked at 100 patients and had CT scans and they had had MRI scans and said, okay, what impact are we having? When you face a patient in the clinic, let's see what impact. MRI detected more disease in half the patients, either more disease or locations of disease that CT did not show. Interestingly, the MRI differed from the CT category of response in 30% of patients. Right? So in other words, MRI was saying the patient is worse, the CT said it's stable. 1/3 of cases, 1/3 of visits. Imagine that. That's huge. And when systemic chemotherapy was changed, in about 1/3, it was only because of the MRI information. This is the sort of impact you could have in the clinic. So clearly we need to develop whole body MRI for precision oncology and advanced breast cancer. There are standards out there. You can start to look at these standards. They are published. They are available. There is a standardized protocol that is now available. When you look at the video, you can stop the video at this point and then just look up where this is, but look at the METRADS guidelines. We've also given you a case report form to be able to report. Okay? There's a woman there. Whoa. Okay? We've done regional assessments. We've given you criteria on what is response, what is progression. We've spelled out how you can judge whether a patient is progressing or responding and what score to give it. And so this patient is getting a little worse. Can you see that? If you measure the tumor volume, you can see that is a 20 cc increase in tumor volume. 20 cc increase in tumor volume. Not like bone scans, right? Where you need 100 cc's or 200 cc's of CO. On an MRI, you will see a 20 cc increase in volume. Okay? With no change in ADC, you can see on the left there. And similarly, we can show you response. So if you were to look just at your CT scans on this particular patient, you can see every one of you would say this patient is worse. No. That was old school thinking. Forget it. That was when you were residents, right? No longer the case, because if you look, you couldn't call this progression because the whole body MRI has gone the opposite way. And if you look at the ADC, you can see the histogram shift. And you can show your clinicians red to start with, green now. This is response, right? If you were to show the T1 weighted image, you would say progression. You would be wrong. So be careful about how you read your scans, because the MRI is clearly showing you how the patient is progressing. So just to begin to conclude now, and here's how you fill up a particular form. So I'm going to skip all of this just to go to my conclusions. I've tried to show you that whole body MRI will replace what you are doing now, which is indirect, inefficient, wasteful. Shall I say that again? Okay. It is already in the guidelines for myeloma. You know these myeloma guys, they're already ahead of you. Leigh-Fraumeni syndrome, it's already there. And by the way, Leigh-Fraumeni syndrome, they get breast cancers, right? So there are imaging standards. You can change the way your clinician thinks. Your clinician has got all these new drugs now. You can change the way he thinks about his new therapies, because you can divide patients from response, stable, and progression. Bone disease becomes 3 categories. And then you can introduce molecular oncology for your patients with breast disease. And here's an example of how we tried to switch treatments using this technology to try to rescue these patients. We failed. But it wasn't because of me this time. It was because of shitty drugs, right? But it wasn't because my technology is bad. It's not my fault any longer. Okay, so if you want to see videos of this and how this all works, look at my YouTube channel. I'm just putting a plug in there for you. So I think we are there to deliver precision oncology. We need to make things better for metastatic disease because breast cancer still kills, which is why all of you exist. But we still need to completely validate and qualify this technique. Thank you very much.